Good day everyone. My name is Dr. Shankar Kupusamy. Today I'll be discussing the management of localized testicular cancer, specifically what happens after the diagnosis has been made. We will focus on three key areas, that is radical inguinal orchidectomy, surveillance and adjuvant therapy. Although stage 1 testicular cancer has one of the highest cure rates of any solid malignancy, the challenge today is no longer how to cure patients. It is how to cure them while avoiding unnecessary treatment and long-term toxicity. By the end of this session, I hope you'll be comfortable making decisions after radical orchidectomy. As a disclaimer, AI-assisted tools were used to enhance the visual design and preparation of these presentation slides. However, all scientific content, interpretation, and conclusions are my own. Before discussing treatment options, we need to be clear about what we mean by localized disease or clinical stage 1 disease. Clinical stage 1 testicular cancer means the tumor is confined to the testis and spermatic cord with no radiological evidence of nodal or distant metastasis. The diagnosis requires three components. First, a high quality CT imaging of the chest, abdomen and pelvis showing no metastatic disease. Second, tumor markers after orchidectomy should either normalize or decline according to their expected half-lives. Persistent elevation suggests occult metastatic disease rather than stage 1 disease. Finally, clinical staging combines pathology, imaging, and tumor marker kinetics. It is not based on histology alone. This distinction is important because subsequent management depends on all three components. As a clinical case, let me introduce a patient. This is a 28-year-old gentleman, presents with a painless testicular swelling. Ultrasound confirms a solid intratesticular lesion. Tumor markers are mildly elevated. CT imaging shows no metastatic disease. He undergoes a radical inguinal orchidectomy, and the histology confirms stage 1 seminomatous germ cell tumor, that is PT2N0M0. At this point, the difficult question begins. Should we simply observe him? Should we give adjuvant chemotherapy? Should we offer radiotherapy? Or should we consider further surgery? This is the decision we face every day in clinical practice, and hopefully the remainder of this presentation will answer some of these questions. Testicular cancer is relatively uncommon overall, but it is the commonest solid malignancy affecting young men between the age of 15 and 40 years old. Fortunately, it is also one of oncology's greatest success stories because modern management achieves cancer-specific survival of nearly 100% for stage 1 disease. Therefore, survival is no longer the main issue with an overall cure rate of nearly 95%. Instead, our challenge is preventing overtreatment. Around half of stage 1 patients are cured by surgery alone, that is the radical inguinal orchidectomy, meaning many patients would receive unnecessary chemotherapy if everyone was treated indiscriminately. Modern management therefore focuses on balancing relapse risk against treatment-related toxicity. Radical inguinal orchidectomy remains the cornerstone of initial management. It serves three important purposes. First, it removes the primary tumor. Second, it provides definitive histological diagnosis. Third, it provides accurate pathological staging that determines subsequent management. The operation must always be performed through an inguinal approach with high ligation of the spermatic cord. A scrotal approach should be avoided because it disrupts the normal lymphatic drainage and upstages the tumor, because the lymphatic drainage is through the different pathway, which is the inguinal lymph nodes, and it may also increase the risk of local recurrence. Remember, before surgery, tumor markers should always be obtained. Okay, and testis sparing can be considered if in the event of synchronous bilateral tumors or in solitary testis, with of course the aid of frozen section if available. Now, before we operate, we must always perform fertility counseling and give the patient an opportunity for sperm banking, and this is especially in younger patients. Patients should also be counseled regarding testosterone deficiency post-surgery, and the option of testicular prosthesis should also be given to the patient either at the time of surgery or for insertion later post-recovery. This slide illustrates the changing philosophy of testicular cancer management. Historically, the emphasis was simply on preventing relapse. Today, because cancer-specific survival is already excellent, reaching nearly 100%, we pay much greater attention to treatment toxicity. Adjuvant chemotherapy is highly effective but carries risk including infertility, cardiovascular disease, metabolic syndrome, nephrotoxicity, ototoxicity, and also risk of secondary malignancies. Therefore, the goal is not to eliminate relapse completely, but to minimize unnecessary treatment while maintaining excellent survival. Active surveillance post-radical inguinal orchidectomy is strongly preferred, and the adjuvant therapies must be risk adapted and clinically justified. The histopathology obtained after radical inguinal orchidectomy fundamentally changes the management. Seminoma, which is the commoner testicular tumor, and non-seminomatous germ cell tumors behave differently. Seminomas are highly radiosensitive and chemosensitive, generally relapse later, and have a lower incidence of occult metastasis. Whereas non-seminomatous tumors are biologically more aggressive and tend to relapse earlier. Consequently, surveillance schedules, relapse risk, and adjuvant treatment differ significantly between these two groups. The pathology report therefore drives the entire management pathway. Most patients with stage 1 seminoma can safely undergo surveillance. Historically, tumor size greater than 4 centimeters and rete testis invasion were considered risk factors for seminoma. Approximately 80 to 85% will never relapse following radical orchidectomy alone in those with 1 or 2 risk factors. In fact, patients with 0 risk factors only has about 6 to 8% relapse rate on surveillance. However, contemporary guidelines regard these factors as useful for counseling rather than absolute indications for adjuvant treatment. For reliable patients who will comply with follow-up, surveillance remains the preferred strategy. One cycle of carboplatin is a reasonable alternative for patients who prefer to reduce relapse risk or are unlikely to comply with surveillance. This algorithm summarizes current evidence-based management. After orchidectomy, patients are assessed for compliance, personal preference, and relapse risk. Patients who can reliably attend follow-up with no risk factor are usually offered surveillance with an established cancer-specific survival of 99%. Patients who are anxious about relapse or unlikely to comply with surveillance or has risk factor of lesion more than 4 cm and rete testis invasion may choose one cycle of carboplatin with a relapse rate outcome of about 2% for those without risk factors and about 9% in those with 1 to 2 risk factors. Routine adjuvant radiotherapy, although seminomatous germ cell tumor is radiosensitive, has largely disappeared because of concerns regarding long-term cardiovascular disease and secondary malignancies. They are strictly reserved for selected patients unsuitable for chemotherapy. Now, coming to non-seminomatous germ cell tumors, and this requires a different approach. The cure rate for stage 1 NSGCT is 70% with orchidectomy alone. About 30% has cumulative relapse risk under surveillance. Even in the event of a relapse, majority will occur within the first 2 years. So, the most important predictor of relapse is lymphovascular invasion or LVI. Patients without lymphovascular invasion have a relapse risk of approximately 15%. Those with lymphovascular invasion have a relapse rates of approaching about 50%. So consequently, lymphovascular invasion is the single most important pathological feature that should be reported in a pathology report. And patients should undergo risk-adapted counseling after surgery based on the presence of LVI. As far as the management algorithm is concerned for non-seminomatous germ cell tumor, it is centered around the lymphovascular invasion. Patients without lymphovascular invasion are excellent candidates for surveillance if the patient is compliant, if the patient is a compliant patient. Patients with lymphovascular invasion may still choose surveillance if they are reliable and understand the higher relapse risk. Alternatively, one cycle of BEP chemotherapy substantially reduces relapse risk to below 5%. The decision should therefore be individualized through shared decision making rather than applying a uniform treatment strategy. In case the patient has contraindication for chemotherapy and unwilling to accept surveillance, then a nerve-sparing RP-LND can be offered, but the surgery can contribute to significant morbidity and best performed in high-volume centers, and therefore, it is not being regularly done as one of the adjuvant modality for stage 1 testicular tumors. To conclude, radical inguinal orchidectomy remains both the diagnostic and therapeutic foundation of management. Accurate staging depends on pathology, imaging, and tumor marker kinetics. Histology determines subsequent management. In seminoma, surveillance is preferred for compliant patients with carboplatin reserved for selected individuals. In non-seminomatous disease, lymphovascular invasion is the key determinant of relapse risk, and one cycle of BEP should be considered in high-risk patients. Finally, remember that cure rates exceed 99%. Our challenge today is no longer simply curing patients, but curing them while preserving their long-term quality of life. As a food for thought, in stage 1 testicular cancer, should our primary goal be to prevent relapse at all costs, or should it be to maximize cure while minimizing overtreatment? Just have a thought. With that, I thank you and I look forward to meeting all of you at ProtiCap 2026.